Thanks, Jessica. And hey, good morning, everyone. I hope folks are refreshed from their break because we have saved one of the most kind of complicated things for last, and something about which we always get a ton of questions on the STD Clinical Consultation Network. And so I hope today's talk is able to give you some of the tools that you'll need to deal with syphilis. As I'm sure you're aware, syphilis is an infection from the bacterium Treponema pallidum, and the origins of this disease are actually so old that they can't be determined with certainty, but we know it's been affecting people for hundreds and possibly thousands of years. Syphilis became widely prevalent in the modern era, and in fact, syphilologists were one of the earliest recognized medical specialists. But despite all that history, and despite a lot of advances in testing and treatment, we're really still struggling to control this particular enemy. And so before I continue, just the usual presenter disclosures, I have none, and the PTC disclaimers that you've seen before. So today we will be trying to recognize the burden of syphilis, identifying the stages of syphilis infection, interpreting syphilis serologic tests, and then determining the appropriate syphilis treatment by stage. At the end, we'll summarize some changes in syphilis diagnosis and treatment in a few special instances. There are some things we won't be talking about today. One is congenital syphilis. Congenital syphilis really deserves an entire talk of its own, as does syphilis in pregnancy. And we won't be talking about syphilis prevention, for example, doxypep, which will be covered by one of my colleagues in another talk. Unfortunately, also, unlike some of the other talks, and unlike the way that I prefer to give some of these, we won't have as many poll questions and opportunities for interactivity because this talk does notoriously go over time, but I will try to make some time during the talk for your questions, in addition to answering them at the end. Okay, so let's talk about that syphilis epidemiology and where things stand now. 2023 is the last year in which we have this nifty infographic from the CDC STI surveillance data, though there are a little bit newer data. You can see here that gonorrhea and chlamydia are starting to trend down in this data set, the first time in a long time, really hopeful news. But on those second two rows, you see the red arrows, continuing to show that cases of syphilis, and specifically congenital syphilis, are increased since the 2019 numbers. There have been, like I said, a little bit of updates to this data, and there is perhaps a glimmer of hope in the newer numbers as we start to zoom in a little bit. All right, but first, before we kind of talk about the more modern epidemic, let's take a look back. So data collection for syphilis actually started in 1941, and it was made a nationally notifiable condition in 1944. Rates of total syphilis were really high at that time, and then followed by a steep decline as penicillin became widely available for treatment. You can see that over the course of the next 20, 30 years, cases really went down and then spiked again in the 80s, peaking around 1990, kind of coincident with the HIV epidemic. After that, syphilis cases declined again, partly in the context of real public health investment around STI control, and really kind of nadir'd around the turn of the millennium. And there was hope at that time to functionally eliminate syphilis from the US. And so to that end, the CDC actually published this national plan to eliminate syphilis in 1999. And it's kind of wild to look back at now in the context of where we are. But I do want to highlight a few key points from the introduction here that I think are really interesting and still really apply. So one is that it says syphilis is easy to detect and cure given adequate access to and utilization of care. And those are really key points because we know that we have kind of the tools to eliminate syphilis, but that access and utilizing care appropriately is key. The second point that they make is that the elimination of syphilis would have really far-reaching public health implications because it removes two devastating consequences of the disease. One, increased likelihood of HIV transmission, and two, the compromised ability to have healthy babies. And of course, unfortunately, we know that this isn't what happened. So zooming in on the current epidemic, you can see here that after that low in 2000 and really kind of blasting off around 2010, there was a large spike in the incidence of syphilis. And this graph shows primary and secondary syphilis specifically. Like I said, there is a little glimmer of hope here. You can see that from 2022 to 2023, there is a slight decrease in these numbers, and that actually continued from 2023 to 2024. But just as you can see from this graph, it really gives you an idea how, despite that decline, cases are still far, far higher than they were at their low. And I also want to point out then how this impacts congenital and maternal syphilis. So like we said, congenital syphilis is the sort of one of the most severe outcomes of syphilis infection, and an area where the news continues to be pretty bad. You can see here that while the cases are going up, though, they are maybe flattening just a little bit in terms of that curve. And that continued to be true from 2023 to 2024. There's like a 1.6% increase year over year. So while congenital syphilis is still on the rise, we do seem to be making a dent in the trajectory. Okay. Well, hopefully that was enough to alarm everyone just a little bit, just enough to pay attention as we talk about what tools we have in order to reverse this epidemic. This graphic from STI Week really sums it up well. If we can talk to our patients about sexual health, then we have what we need to detect and treat syphilis. I won't repeat today any information about kind of sexual history taking. You already got a really expert lecture on that from Dr. Kohal. But I will make a note about how we use screening for asymptomatic people as an important part of routine healthcare and why that matters. So these are the current CDC screening recommendations for syphilis. You can see that in some groups, for example, men who have sex with men or people taking PrEP or people with HIV, there is some amount of recommended routine screening and more frequent screening recommended for people who are deemed at risk. But what does at risk really mean? The CDC does offer an explanation here, specifically MSM under the age of 29, incarcerated populations, individuals engaging in transactional sex work, and people in high prevalence eras. So this is like a pretty narrow and actually I think pretty complicated definition of risk that's really hard to employ at the bedside when you're seeing a patient. And so to that end, I want to talk about maybe a broader definition of who constitutes this at-risk population. This map actually comes from a 2023 MMWR about missed opportunities for preventing congenital syphilis. The shaded areas represent counties that they designate as high prevalence, where annual syphilis rates are above this 4.6 per 100,000 cutoff. That might seem arbitrary, but it actually comes from these Health and Human Services Healthy People 2030 goals for STI epidemic control. And it's useful because we see that if we employ that here, that about 3/4 of the US population lives in one of these high prevalence areas. So the authors of this paper concluded that since living in a community with high syphilis rates is a lot of people's most significant risk for infection, geography-based screening stands to improve uptake and also reduce stigma that's associated with the risk-based testing we were talking about earlier. And since most of the US lives in one of these areas with a high syphilis prevalence, I would actually argue that routine syphilis testing should really be the default. And so rather than trying to single out folks that we think are necessarily high risk, we should start from a perspective of we should offer syphilis testing and then potentially decrease the frequency of that depending on who might be a low risk. Another argument for screening for syphilis is the frequency with which latent disease really becomes the burden of infection. So in 2024, there were over 140,000 cases of early non-primary, non-secondary syphilis, as well as late syphilis or syphilis of unknown duration. Those two categories comprised kind of the latent infection stage. And then that same year, there were just over 40,000 cases of primary or secondary syphilis, that is to say, symptomatic disease. So really a large majority of new syphilis cases are diagnosed in people with no current symptoms, and screening is the primary way that we have for preventing transition and late complications in those patients. Okay, so we've covered just a little bit about talking to patients, and we're going to talk about testing and treating patients. But before we go there, I actually want to comment on one stage that I think is missing from this, which is staging. And so interpretation of the testing as well as selection of treatment really depends on knowing what stage of syphilis infection your patient has. And that means understanding the natural history of disease. So that's what I'd like to talk to you about next. All right. I'm sure you've all seen some figures like this. This one actually comes from our New York City PTC syphilis monograph that I'll link to at the end. But this is the natural history of syphilis, going from incubation period through primary and secondary infection to latent infection and then tertiary late stages of disease, as well as, of course, the neurologic manifestations. And we're going to talk about each of these as we go through, but I'll focus less on those late stage manifestations since they're a bit less common. These definitions here and the way the stages are named differ just a little bit from others that are often used in the context of surveillance. And so I've added those here just for clarity. So early latent is also called early non-primary, non-secondary. You heard that as we were recapping CDC data, late latent of unknown duration or late. But those definitions kind of in the colored boxes are how we define treatment. And so that's how I'll be referring to them here. All right, and with that, let's go to our first case. And just I want to make a note that for clarity purposes, these aren't exactly in the order of disease progression, but I hope that they'll kind of form a good narrative that's easy to remember. So this is Joseph. He's a 24-year-old bisexual male, and he's coming in today with an ulcer on his penis that had been there for a few days, but it doesn't really hurt him. He's not that bothered. When you go to examine him, you find a little bit of inguinal lymphadenopathy, but no other symptoms, and he's feeling generally pretty well. And so what do we want to do for Jack? Well, so first of all, talking about staging. And none of these are really going to be mysterious. All these stages will be pretty classic, as is Jack's. This is primary syphilis. The stage of infection is characterized by these ulcerative lesions, which we call chancres. They can differ pretty considerably in clinical appearance, and so it's actually really important to take a good history and have a high index of suspicion. This, like we said, is one of those classic lesions, as is this. These lesions form at the site of inoculation, can often begin as a macule that progresses onto a papule that then erodes to become this classic painless ulceration. The examples here are really visible, but it's actually important to remember that in reality, as many as 60% of people diagnosed with syphilis don't ever recall having that chancre. And that's partly because they're classically painless, though we're going to circle back to that later. And because of that, they can really go unnoticed in sites like the rectum, the vagina, or in the mouth, where they're not easily visible. It is also worth noting that they are often associated with some regional lymphadenopathy, which may be a better telltale clue. Syphilis chancres, primary syphilis, occurs 10 to 90 days after the initial infection, and it is highly infectious. These ulcers are teeming with treponemes. And left alone, they actually resolve spontaneously in about 6 weeks. So again, when people kind of don't notice these painless lesions that might be somewhere out of sight, they go away on their own, and they often aren't coming in to see you. All right, but so Joseph, with a few days of a painless ulcer and some inguinal lymphadenopathy, has this really classic presentation of primary syphilis. All right. But we said we'd circle back to that classic definition, and the 2021 STI guidelines actually do make a note about this. So while we often say painless ulcer or chancre, they point out that it's actually really common to have these multiple atypical or painful lesions at the site of infection. And this study here on the right was conducted among MSM at a sexual health clinic in Melbourne. And in that study, almost half of the primary syphilis lesions were painful and about 40% were multiple. This is particularly true with rectal lesions. And so, as always, syphilis can look like a lot of different things, and it's called the great imitator for a reason, and you need to keep that high index of suspicion. All right, so later that day, you meet Janice. Janice is a 25-year-old woman. She's coming in for routine STI testing, and she tells you that she's actually in a new relationship. As it happens with a bisexual male who was recently diagnosed with syphilis, it's Joseph. She tells you that she has no lesions, no rash, and on exam, you really find nothing. Everything is totally benign. And so Janice has no symptoms at all. Could she have syphilis? The answer is yes. So Janice is likely in what we call the incubation period. Like we said, the incubation period can be up to 90 days after exposure to syphilis. And so people who have had sexual contact with a person who gets a diagnosis of primary, secondary, or early latent syphilis less than 90 days before they come in for evaluation should be presumed to be infected, even if serologic tests are negative. And so Janice fits here into this incubation stage. All right. And next, we're going to meet Jordan. We're going to be spending a lot of time with Jordan. Jordan is a 30-year-old man who has sex with men. He's been on PrEP for the last 6 months. And when you ask after his health since the last visit, he actually tells you a story that's pretty extensive. First, he notes that he had a rash about 6 weeks ago. He went to an urgent care clinic where he was prescribed a topical steroid. And while the rash didn't go away immediately, it faded over time and ultimately resolved kind of on its own. He does share with you some pictures from that. And these are actual pictures from a similar patient who provided consent for us to share these. So this is the rash. It was diffuse, it was non-pruritic, non-painful. There were these erythematous macules and patches that were all across the chest, axilla, abdomen, bilateral, and upper and lower extremities. There's the chest and back. And so I don't think anyone will have any trouble figuring out the diagnosis here. This is secondary syphilis. It's characterized by these localized or diffuse mucocutaneous lesions, so not the sort of very localized chancres before, often concurrent with generalized lymphadenopathy. And other signs can include other kind of dermatologic manifestations, including mucus patches, condylomalata, and alopecia. And it's important to know that the primary lesion might still be present, so you can really see overlap here. The fact that we see mostly dermatologic manifestations are a reflection of the fact that syphilis best multiplies in lower temperatures. So it really likes kind of the surface of the skin and those mucous membranes. And we talked about kind of a few of those alternative manifestations aside from that classic rash. And here you see a picture of condylomalata. These flat sort of warty lesions that are typically on the genitals and the site of infection, but different in that they have a kind of smooth surface. So condylomalata is sort of flat warts. Also, a pretty common manifestation is alopecia, which you'll see on the next slide, and mucus patches, which kind of look like light or white colored plaques, often in the mouth is the most sort of visible area. And here's that alopecia. Syphilis, secondary syphilis, is really characterized again by bacterial dissemination, and so it can be associated with more systemic symptoms, things like low-grade fevers, fatigue, and this painless but generalized lymphadenopathy, unlike the localized lymphadenopathy from before. This tends to happen about 4 to 8 weeks after an infection, and like the chancre, also resolves spontaneously, usually somewhere around 6 weeks. But like primary syphilis, this is a highly infectious stage, with treponemes present at those skin lesions and all kind of mucous membrane sites in really high numbers. All right. We mentioned that the dermatologic manifestations of secondary syphilis are typically the most prominent and oftentimes what people will kind of come in for, but syphilis can actually affect almost any organ system. And so here we have kind of a list of syphilis manifestations in the GI tract, renal tract, musculoskeletal, but even this list really isn't comprehensive. We've had folks come in with pulmonary lesions from syphilis, and the list just goes on. We'll talk about the nervous system complications a little bit separately, but I do want to point out that they're actually possible and in fact more likely during this stage than some of the other ones. And so given kind of these protean manifestations, and I know I've said it before, it won't be the last time, but you really have to keep this high suspicion for syphilis in your patients who have risk factors and are coming in with symptoms. All right, so for Jordan, at that initial presentation 6 weeks ago, he had a rash that was a classic example of secondary syphilis. But then as time went on, his symptoms resolved. And so he progressed into this stage that we call early latent disease. And we'll say more about that in just a little bit. But since he didn't get tested for syphilis at that initial presentation or receive any antibiotics, he is at risk for going on to develop some additional complications. And so at his visit with you, he tells you that just a few days ago, he was kind of having a hard time hearing the TV. He went into the ED for it and actually got seen by ENT, who recommended an MRI. The MRI was unremarkable, and he was discharged and told to follow up outpatient. And then at today's visit, he tells you he's also having a hard time reading his homework. You get a thorough neurologic exam, and you see some decreased visual and auditory acuity, but no other cranial nerve abnormalities. But you do send him urgently to the ophthalmology clinic. They examine him there, and on the note from his fundoscopic exam, they report panuveitis. All right. And so now Jordan's really going on to develop a number of other classic manifestations of syphilis, and these are the ocular and otic disease that we really worry about, especially for people who have recently had secondary syphilis. So ocular syphilis presents often as sort of panuveitis, but can involve any structure in the anterior or posterior segment in the eye. So conjunctivitis, keratitis, optic neuropathy, retinal vasculitis, and it can lead to permanent vision loss. So this is a really big deal. Otosyphilis tends to present with cochlear vestibular symptoms, so things like tinnitus, vertigo, and sensorineural hearing loss. It can be unilateral or bilateral, often has pretty sudden onset, and it can progress rapidly. Like ocular syphilis, the damage can be permanent in these, so equally important to really think about. And note that both of these are really emergencies and need to be diagnosed and treated quickly. All right. There are, of course, other neurosyphilis manifestations. The other one that I really want to sort of mention here is acute syphilitic meningitis. The symptoms of this are kind of similar to other forms of meningitis, though they often can be a bit more subacute. Things like headache, nuchal rigidity, photophobia, nausea, vomiting, and including seizures, though that's a bit less common. There's also a rarer entity called meningovascular syphilis, which really kind of comes with more of a vasculopathy, vasculitis, and stroke-like symptoms. But the point that I want to make for most of us in practice is actually that when you have someone in whom you either suspect syphilis or you've already made a new diagnosis, it's really important to screen them for these symptoms that might suggest that they need further workup for one of these neurologic manifestations. And so this is actually a nice little screener for neurosyphilis that comes from the DOH in Kings County, Washington. And it's something that I use and actually have recently gotten somebody sort of diagnosed and treated for ocular syphilis for, because I remembered to go through all of these. So this consists of just some screening questions. For otosyphilis, you want to ask about new trouble hearing, ringing in the ears. Ocular syphilis, changes in vision, flashing lights, floaters, or blurry vision. And then for other kind of meningeal syphilis, thinking about headaches, confusion, memory, concentration changes. I'll note that, a lot of these really can have sort of a, non-specific positive things, headaches, confusion, blurry vision. And so it's kind of important to dial in on the time course of that symptoms, but especially in those folks who are high risk, like we said, folks with secondary syphilis, you should have a really low threshold to send them off to an ENT or ophthalmology colleague for a detailed exam. All right. And so Jordan now has moved from that early latent stage into this early ocular and otic syphilis stage. All right, and getting towards the end, we're now meeting Jackie. So Jackie is a 29-year-old female. She's coming up for a follow-up visit, and she was recently seen in the family planning clinic where she noted that she was considering becoming pregnant. They offered her comprehensive STI testing, and that included syphilis testing. She comes back with a positive result for which she's coming to see you. A pregnancy visit from that a pregnancy test from that visit was negative, and you actually have some prior results where syphilis testing 2 years ago was negative. She doesn't have any symptoms today, and she has a normal exam. So this is kind of the definition of latent syphilis, which is defined by the absence of symptoms and differentiated from early latent syphilis, or differentiated into early and late latent syphilis by the duration of infection, with 1 year kind of being the watershed that divides those two. It's actually an important distinction because early latent disease carries a significant risk of relapse and intermittent bacteremia. And you noted that in Jordan's case, he had kind of early latent disease that did relapse into neurosyphilis. And then late latent disease actually carries kind of a lower risk of infectiousness or relapse to symptoms, though that relapse risk, especially for some things like neurosyphilis, is actually non-zero. And so Jackie is here in this late latent category. You know that she had her last syphilis test 2 years ago. She doesn't have any new symptoms, and we can't really be sure at what point she acquired syphilis. And so that's why she kind of fits into this category. We don't know that she had an infection within the last year. And so we alternately call this either late latent or syphilis of unknown duration, which we treat similarly. Okay. And so, since I think we have a little bit of extra time, and I know I'm moving fast, I just want to take a brief pause here and see if there's any questions on the natural history or the staging of syphilis.
All right, we do have a couple questions here. Do you treat seronegative patients in the exposed or incubation window when they have had a known exposure to syphilis?
Yeah, so we'll get into that in a little more detail later in the presentation, but absolutely yes. We know that in that first 90 days after exposure, and I'm talking about known exposure to someone who has gotten a diagnosis of syphilis, in that window period, we can't trust our serologies, and we do recommend empiric or presumptive treatment for those folks.
Thank you. Another question, could you comment on patients who do not have access to ophthalmology or ENT? Specifically, would you be able to comment on how management would change?
Yeah, and that's a difficult situation. For folks who are coming in with either suspected or known syphilis, who definitely have these symptoms that would make you concerned for ocular otic or other CNS syphilis disease, I would really just suggest that they actually go somewhere where they can be evaluated. And if that has to be an ER, then that may not be optimal, but that may be what there is. Like we talked about, the stakes are pretty high. Irreversible vision loss, irreversible hearing loss. Those things are really significant. We can't empiric treatment for sort of CNS syphilis is pretty impractical. We'll talk about kind of what treatment looks like a little bit later. And so it's not something where you could just take someone who has some symptoms and then offer them, a course of IV penicillin, probably empirically. Okay. Well, thank you for those. And with that, we will move on to testing. And so syphilis testing is confusing for a lot of people. And if that's ever been you, it's absolutely not your fault. We just don't have tests that give us a straightforward yes/no result at every stage of infection, or tests to give us a straightforward yes/no about successful treatment. And this is despite just years and decades of research into trying to improve these tests, during which time we've made some, but not the kind of progress that you would hope for. All right. And so what are we talking about when we're talking about syphilis testing? So here's one thing we're definitely not talking about most of the time. And so that's kind of diagnosing syphilis via a direct detection method. And so there are a few options that exist for this. The one that you'll often see referenced in text is dark field microscopy, which is unfortunately something of a lost art and not available at most clinical settings. It involves taking a specimen from an active chancre and looking at it under a special microscope. Ditto direct fluorescent antibody testing to look for bacteria in the same way. And then also T. pallidum nat, PCR type tests. These are actually becoming a little bit more available. There are some lab-based tests out there for this, but there are no FDA-approved tests that are commercially available. And so this really isn't a primary strategy for diagnosing syphilis, and not something we're going to talk about today. What we're really talking about is serologic tests. And these belong to one of these two classes based on what kind of antigen that they recognize. So first we'll talk about the non-treponemal or lipoidal antigen tests. There are a couple of different ones of these, but this is primarily the RPR. These test for reactivity antibodies to a antigen composed of a mix of cardiolipin, cholesterol, and lecithin. All these really sort of non-specific things that are present in sort of increased quantities in the T. pallidum bacterium, but also to some degree present in normal healthy human tissue. And so that antigen response is both to the bacteria as well as to the host tissue damage. They do have some drawbacks. Up to 11% of positive tests for these non-treponemal antigens are actually probably not due to T. pallidum. they do have the advantage of the degree of reactivity changing over time with the disease course or with treatment. So increasing in response to perhaps new infection and decreasing in response to successful treatment. Their other main disadvantage is that they're typically manual. This is not a automated process. This is a lab tech sitting at a bench, manually diluting serum and looking for this reaction. On the other hand, we've got treponemal tests. These are reactive specifically against the T. pallidum bacterium. They are more specific than the non-treponemal tests, but unfortunately they often remain positive for life. And so they're not that useful as we're trying to distinguish between a recurrent infection or not. And they don't really give us much information typically about successful treatment. On the plus side, they're generally automated, and so labs can really process large volumes of these samples quickly. And we'll kind of talk about how that plays into selecting the different testing strategies that your lab might offer. Names of these tests, there are a few that you've definitely come across. The non-treponemal or lipoidal antigen test that is employed just about in every lab is the RPR. The VDRL works very similarly and is sometimes employed with CSF. But most serum specimens that you're going to be sending off are going to get you an RPR. For treponemal tests, there are more options. Testing for antibodies via an enzyme immunoassay or chemiluminescence assay, as well as things that are labeled the fluorescent treponemal antibody and treponemal pallidum particle agglutination tests. These are all really just different strategies for detecting the presence of those T. pallidum specific antibodies. If anyone gets really curious, there is an MMWR from last year with lab recommendations for syphilis testing that goes into a tremendous depth about kind of how these work and how they perform. But for our purposes, what I want to spend a little more time on is talking about the different algorithms. And so those serologies can be deployed in one of two different ways, which have their advantages and disadvantages and differ typically by lab or institution. The differences in which type of test is performed as the initial test, and then how confirmation is achieved in the setting of a positive test. And since we get a ton of questions about this, I'm going to walk you quickly through both of them. So we'll start with the traditional algorithm. This one starts with a non-treponemal test, that RPR. If it's not reactive, you're done. There's no serologic evidence of syphilis. There's some limitations here. We talked about how in the incubation period, this might not be reliable. And sometimes in early primary infection, the patient might not have generated that antibody response necessary to turn this test positive. If the RPR is positive, this cascade reflexes to a treponemal test, one of those options that we discussed. If that's non-reactive, we're thinking that this is probably a false positive RPR, one of those, approximately 11% that we talked about being due to something other than T. pallidum. If it's reactive, then we have evidence of syphilis infection. So you need that positive RPR and then that positive follow-up treponemal test. It doesn't, unfortunately, distinguish between prior treated infection or current infection. There are some ways to help think about that with the RPR, which we'll talk about a little later. All right. On the other hand, we have the reverse algorithm, and this starts with a treponemal test, often something like that EIA. If that's not reactive, you're done. No evidence of syphilis, with the same limitations as with the RPR. If it's reactive, you move on to a non-treponemal test, the RPR. And if that's reactive, now again, you have evidence of syphilis infection. It becomes a little bit more complicated if it's negative. Evidence of syphilis infection with the same caveats as before. But if it's non-reactive, you actually reflex to a third kind of tiebreaker test, one of the other treponemal tests, but different from the first one. If that's reactive, again, that constitutes evidence of syphilis infection. So you have kind of 2 out of 3. And if it's not reactive, then once again, you're thinking it's a false positive. I also want to pause here and ask, are there any questions about the reverse versus traditional algorithms? All right, then we'll follow those up at the ends. Okay, and so we mentioned that there are some issues around these tests, not doing a great job of distinguishing between prior infection and current infection. The treponemal test specifically tend to remain positive for life. And the RPR can remain reactive despite successful treatment as well, or alternatively wane over time, even without treatment. But comparing RPR titers to prior results is really important for evaluating reinfection as well as successful treatment. And then what about CNS disease? So we've talked all about kind of serologic testing, but I'm sure you've all kind of heard about doing CSF studies like we do for other CSF infections for syphilis. And so you absolutely can. And neurosyphilis is defined in part by CSF abnormalities that include things like pleocytosis, so more than 5 cells per ml in most patients, or more than 20 cells per ml in folks with HIV. Elevated protein, which unfortunately has pretty limited sensitivity and specificity, or a reactive CSF VDRL. And this is kind of the most specific test for neurosyphilis, but unfortunately has pretty suboptimal sensitivity. And so while CSF testing can be really important for diagnosis of neurosyphilis, the CSF testing parameters always have to be interpreted really carefully. Also, you can imagine that if we were to LP everyone with any of those symptoms listed in the screening document that we looked at before, we might end up doing a whole lot of LPs. And so there are actually some instances where maybe we don't need to do this. And again, the CDC guidelines actually cover this. And they had some updates from the prior set of guidelines that really removed sort of the recommendation for lumbar puncture in a few circumstances. So one is isolated ocular symptoms without any cranial nerve dysfunction, and the other is otic syphilis, kind of in all cases, again, without any other kind of neurological deficit. For either of those cases, we know that having a hearing exam or a fundoscopic exam that diagnoses syphilis alongside those positive serologies really establishes the diagnosis and merits treatment as for neurosyphilis. So the treatment is not different. We also know that in all cases of neurosyphilis, including that which was initially diagnosed with CSF, we no longer have to repeat a CSF exam at 6 months, as long as there's an adequate RPR response. So that fourfold, and we'll talk about this in a minute, but that RPR titer decline over time really correlates strongly with normalization of the CSF parameters. And so for most folks, we don't need to do that. Okay. Other frequently asked questions about syphilis testing. When do I need to report this? And unfortunately, I don't have as concrete an answer for you as I might like here because it varies a fair amount by state or locality. It is generally a reportable disease. Most labs will report this automatically, but if you're not sure about the procedures in the lab where you are, then it's worthwhile to check with them and or your local health department. All right. So I hope that was a pretty good overview of syphilis testing. Now we're going to move on to treatment. And this part is fortunately one of the easier parts. There's actually just kind of a couple of different buckets for early and late disease and a couple of different agents that you need to know about. By and large, treatment for syphilis continues to rely on penicillin, to which kind of miraculously, resistance hasn't been observed over the entire time that we've been using it for this purpose. We primarily use long-acting benzathine penicillin G, you might know the name Bicillin, and that's great because it sustains these treponemocidal drug levels for 7 to 10 days after just one dose. We know that the syphilis bacterium has these really long generation times, division times, and so we think that having sustained drug levels over that time are actually really important for bacterial elimination. Aside from penicillin, though, we know that doxycycline is probably a reasonable alternative, and this has come up a lot primarily in the context of shortages for IM penicillin. And so there is actually one of these, again, going on now. Our clinic is a little bit short. And we know that the retrospective studies that have looked at how people did when they got doxycycline in the context of one of these shortages all support its efficacy. Oh, and this last line is just a little bit outdated, though there's a similar thing happening now, where every time there's a penicillin shortage, the FDA attempts to secure kind of alternative supplies. But the bottom line for this slide is the mainstay of treatment for most stages of syphilis is benzathine penicillin G, and then doxycycline as an alternative if that's unavailable, which does now have some pretty decent evidence for its efficacy. All right, I said that syphilis treatment fell into one of two buckets, and the first bucket is early infection. And early infection includes all of the stages we mentioned up through that kind of early latent syphilis. So that's incubation, primary, secondary, or early non-primary, non-secondary, which is early latent. Treatment for all of those is just the one dose of that benzathine penicillin G, or alternatively, doxycycline 100 milligrams twice a day for 14 days. For CNS disease, things get a little bit more complicated. We think that really high doses of penicillin are necessary for penetration into that space. And so the treatment recommendation is 18 to 24 million units per day, either as a continuous infusion or every 4 hours for 10 to 14 days. The alternative that you see listed in the CDC guidelines is procaine penicillin G, IM, with probenecid to boost and sustain the levels there. Unfortunately, procaine penicillin G has not been available for the last couple of years. And so really kind of intravenous penicillin G is the mainstay of treatment here. All right. And then late latent disease, finally, we talked about how syphilis has these really long generation times. And with that and the fact that we think in this stage of disease, infection is particularly kind of deep-seated and in harder to reach kind of reserved compartments, we think that an even longer duration of antibiotic is necessary. And so with that, we prefer 3 doses of the benzathine penicillin G or 28 days of doxycycline. The benzathine penicillin G is typically administered at 1-week intervals. However, this often runs into a little bit of a scheduling issue. Things happen, weekends, holidays, patients miss visits. And so there is some really specific guidance around kind of what to do for folks who are not able to get in on that exact 7-day schedule. And so this is kind of from the CDC guideline. Essentially, the interval of 7 to 9 days is what they would call preferred. And an interval of 10 to 14 is maybe acceptable for an interval between doses before having to restart the sequence of injections. Your local health department might have a slightly different policy, and so it's important to check with them, but this is what I tend to adhere to in my practice. This is different for pregnant women. There's sort of a lot less margin for error here. And so the optimal interval is stated at 7 days, but missed doses more than 9 days are just not acceptable. And in that context, the patient is recommended to restart the full course of therapy. Okay. And so after treatment, how are we following people up? We talked about how those RPR titers do come down over time. And the times that we should be looking again for most folks are at 6 months and 12 months. And then again for 24 months for late latent disease. And I'm sorry, that should say late latent. An inadequate serologic response after treatment is failure for titers to decrease by 4 times, either 12 months after treatment for early disease or 24 after latent disease. So we're looking for that 4-fold decrease that we're going to get into more detail on in just 1 second. So these are the RPR titers that you've all seen. And understanding these is actually critical to understanding, like I said, prior infection versus new infection, as well as treatment response. And these cause just a tremendous amount of consternation. And it's understandable because these are a lot more complicated to interpret than other tests. And so what do these titers mean? The first thing that I kind of want you to know is what this looks like in real life in the lab. And so on the left-hand side here, you see a picture of an actual RPR test card. In the lab, the patient's serum is taken and it's combined with that lipoidal antigen, cardiolipin less than cholesterol, as well as these coated charcoal particles. And the mixture is observed for clumping, which is called agglutination. For positive tests, the most dilute specimen at which the agglutination is visible is the titer that gets assigned to this result. And so you can see here 1-to-1 serum to antigen in equal quantities. You see the clumping, and it keeps going 1-to-2, 1-to-4, 1-to-8, 1-to-16. And as you get towards 1-to-32 and 1-to-64, it starts to get a little less clear and then goes away by 1-to-128. You'll hear the titer referred to, or the change in titer referred to by both dilutions and fold, but this is where the kind of dilution part comes from. Let's look at some examples. All right, so first, we're going to talk about what is a 1 dilution change and what is a 2-fold change. So these are the same thing. 1 dilution takes you from a 1 to 16 to 1 to 32, kind of like you just saw on that card. And like you can maybe guess from that card, there's some room for subjective interpretation and assigning kind of where that cutoff is. And for that reason, to be meaningful, to constitute a meaningful change, what you really want to see is that 2 dilution change or a 4-fold increase or decrease in titer. So an example would be going from 1 to 32 to 1 to 8. For clarity, I recommend really just getting rid of the kind of dilution change as something to remember and just sticking with that 4 change. So we're really just multiplying or dividing by 4. And that's the minimum change that we want to see to constitute either new infection or successfully treated infection. And so going from 1 to 8 to 1 to 32, we would worry about either treatment failure or new infection. And going from 1 to 16 down to 1 to 4, we would feel good that we'd achieved adequate treatment. All right. And so I'm just going to ask to hold on for just a minute with any questions about titer interpretations, because we will talk about that there at the end. Okay. So we talked about kind of how to follow up testing in people with newly diagnosed syphilis, but what else do we need to do for them? One important thing is partner notification. And so this really kind of gets broken down into different strategies based on what stage of syphilis that people are diagnosed with. So once again, stage is really critical in determining treatment and follow-up for your patients. We know that transmission happens through microscopically abraded skin as well as mucous membrane lesions. And we know that those are really most common during that first year in primary, secondary, or even early latent syphilis. We know that they're easily missed. But we do know that also the presence of syphilis at the skin and in those mucous membranes does go down with duration of infection. So for primary syphilis, we recommend that partners from the last 3 months be brought in for evaluation, but also presumptive treatment. So like we talked about when we talked about incubation period, you can't rely on serologies here. And folks who have been exposed, who have had sex with the patient with primary syphilis, just get presumptive treatment. For secondary syphilis, sex partners from the last 6 months should be brought in for evaluation. And then presumptive treatment of everybody who's been exposed within the last 3. And then finally, early latent syphilis, you go back to 12 months, again with presumptive treatment of those recently exposed patients, but testing and then treatment as indicated and folks who are exposed at other times within that last year. For folks who have late latent syphilis, it's a bit less clear since, presumably for the more recent part of their infection, they've been much less infectious. It's recommended for any long-term ongoing partners who were exposed to be brought in for syphilis screening during that time. All right. For ocular, otic, and neurosyphilis, really kind of the partner notification interval depends on the otherwise how they would be staged. So if they're coming in with neurosyphilis in the context of secondary syphilis, the secondary syphilis recommendations apply with 6 months, primary syphilis 3, etc. All right. And so this just kind of breaks that down one more time. Again, it spells out just a little bit complicated, but the table that we saw on the last slide is actually in that syphilis monograph that we'll link at the end of this presentation. It's also really important that in addition to partner notification, your patients that you're diagnosing with syphilis abstain from sex until at least 7 days after they and their partners start treatment and until any symptoms that they're having are resolved. Okay, so I think we're finishing a little bit early, which is fabulous, but I want to leave you with just a couple take-home points before hopefully we get to address lots of questions. So for one, syphilis case rates are still high. There's maybe a glimmer of hope in the last couple of years worth of numbers, but we're still way above where we were just 20 years ago. Think about testing your patients for syphilis if they're vulnerable to infection, and that really means taking a good history to find out about some of those risk factors, but also just thinking about, does my patient live in a high prevalence area, knowing that that's most places, and kind of defaulting towards screening if there isn't a clear sort of risk mitigating thing. When we're screening and thinking about testing your patients, always for syphilis when you're screening for other sexually transmitted infections. It's important to know which syphilis testing algorithm is in use at your institution because it really does play into how you can establish a diagnosis, as well as to how you can stage disease and follow up treatment. Treatment is based on the stage of disease, and so it's really important to remember to screen for those neurologic, ocular, and otic manifestations. And finally, and this is the last time I promise, identifying syphilis cases does require just a high index of suspicion, given all of the different manifestations that you can see, as well as the high prevalence of latent disease. And so being on the lookout for syphilis and having a low threshold to offer someone screening. Thanks all.
Fabulous. Thank you so much, Dr. McLean. That was a fantastic presentation. We do have a few questions here, and just a reminder to everyone joining us, if you have any questions about syphilis, any questions for Dr. McLean, to please put those in the Q&A box located at the bottom of your Zoom screen. So we have a couple questions related to testing. So one question, why would you choose to use the reverse algorithm versus traditional algorithm?
Yeah, the actual sort of more practical answer here is that oftentimes we don't choose. At my institution, we have a lab. The lab has its syphilis algorithm. And so that's what happens when we send off a serology. There can sometimes be opportunities for sending one of the specific, say, treponemal tests, if your lab would otherwise start with an RPR. But most of the time, it doesn't constitute a clear choice. There are some instances where you might prefer to start with a specific treponemal test. For instance, in folks where you thought an RPR titer might have waned over time and you're suspicious that there was kind of a remote syphilis infection that never got treated. And then also sometimes where you might be worried about an RPR that could be sort of falsely positive for other reasons, though that tends to reflex again to that specific test. Labs choose one algorithm over the other, mostly based on kind of throughput and other issues, including the sort of prevalence of folks with a positive treponemal test at the beginning of their cascade. And so most of the time, again, you just have to kind of work with what you have. There's one of the cases that we'll go into where we get a little bit more into the nitty-gritty of situations where you might prefer one sort of testing over the other.
Great, thank you. And another question related to testing algorithms. My understanding was that traditional algorithms can miss 3% of syphilis cases that could have been detected with the reverse algorithm. Could you clarify if that's accurate?
Yeah, and so there are some differing estimations of that number, but I'm really glad you brought that up. Like I said, we'll kind of dig a little bit deeper in one of the cases on Thursday, but there is a fraction of folks for whom that RPR might be negative when they do indeed have syphilis. Circumstances where that might happen could include, like I said, someone with remote infection where their RPR titer waned over time. Early infection, there may be a slight advantage to starting out with one of the treponemal tests, depending on which one is kind of at the beginning of that algorithm. And then there are some other things like prozone effect that can interfere with the RPR for other reasons, but don't have that issue with the treponemal test. And so there's kind of a small grab bag of different reasons why a traditional algorithm might miss something that a reverse algorithm would pick up. But for the broad majority of folks, these are going to be generally equivalent.
Great, thank you. A question here about using doxy during the penicillin shortage. We're seeing patients who were treated with doxy during the shortage of penicillin whose titers have not decreased significantly. Are you seeing this, and how are you handling it?
Yeah, there have been reports about folks with either sort of slower decrease in RPR titers or sort of less frequent resolution. Mostly the first one, sort of taking longer for the RPR titers to wane. What I usually tell most folks is that it's really important to adhere to those definitions of timing for defining adequate treatment response. And so that whole 12 months for early disease, including primary or secondary, before saying that you failed to get that RPR titer decline, or 24 months for late latent disease. We also know that there's some other things that kind of interfere with expected decrease in RPR titer, like starting out with a really low titer. But from what we have for the moment, we think doxycycline in terms of serologic response is still quite good, but this is one of the reasons we maybe continue to prefer penicillin.
Great. Thank you so much. All right. We have a specific case question here. A attendee had a patient who's a man who has sex with men, was treated with penicillin back in 2023 with an RPR of 1 to 128. After 9 months, repeat RPR was 1 to 16. Titer in December of 2024 was 1 to 8. Last titer last month was 1 to 4.
Yeah.
Does the patient need to be treated?
And so this is actually a really common question, and thank you so much for asking it. And so this all comes back to kind of interpreting RPR titers and defining the kind of serologic response that really reassures us that treatment has been successful. And again, it's really that fourfold titer decrease that's the marker for success. It's not that uncommon for people to have a persistently positive RPR despite treatment. I'm not sure what stage of infection your patient had or exactly when they were diagnosed and treatment was started, but you had at 9 months, the RPR titer had gone from 1 to 128 all the way down to 1 to 16. And so you can see that really this is and I'm going to struggle with the math here, like an 8-fold decrease in the titer, which is more than adequate to suggest treatment success. For your patient who now has that titer of 1 to 4, I would suggest continuing to follow them if they continue to be vulnerable to a new syphilis infection. And if you see that titer increase 4-fold, that would suggest a new infection. And in that instance, I would suggest retreating.
Great. Thank you so much. Another question from somebody with a similar situation. When a patient presents with titers that have changed from 1 to 16 to 1 to 8 to 1 to 4 and then back up to 1 to 32, they received treatment at that 1 to 16 mark, tested 6 months to a year apart. Does this indicate reinfection? So just coming back to this point of at what point are we thinking this is reinfection? At what point are we treating and retesting and moving on?
Yeah. So there's always with RPR titers the possibility that something that is not syphilis can be driving some sort of increase. But in a case like this, you have someone whose titer went down successfully after treatment. So from 1 to 16 to 1 to 4, a 4-fold decrease, and then jumped back up again to 1 to 32. So an 8-fold increase. And that really would make you suspicious for a new syphilis infection in somebody who had an ongoing opportunity to be exposed to syphilis. And if they did have that exposure potential, then I would absolutely suggest treating. If they had just absolutely no exposure potential, depending on the exact timing of these, you might worry about sort of treatment failure, but more likely this is new infection and I would treat.
Great, thank you. If folks have any other questions for Dr. McLean, this is your time to put those here in the Q&A and we can answer them. If questions come to you later, that is totally fine. Please save those and we can get to them in tomorrow morning's Q&A. I think at this point, I don't see any additional questions. So we can pause. Okay. So thank you so much, Dr. McLean, for that presentation. That was fantastic. And I'm just going to close us out for the day. All right.
Switch my screens. Okay, so we are wrapping up for the day. I just want to thank everybody so much again for being here, for spending this morning with us. Thank you to all of our speakers for their fantastic presentations. We will be back here tomorrow morning, starting again at 8:45. Same Zoom link you used today to join. Friendly ask, if you received the Zoom link forwarded from somebody else, please let us know. We want to make sure that you are registered for the training so that your attendance counts and so that you can be eligible for CE credit as well. And as a reminder, CE credit is only available for folks who attend all 3 days of the training, today, tomorrow, and Thursday. So again, same Zoom link tomorrow, 8:45 a.m. start. We will start with Q&A in the morning. Any questions we didn't get to today, we will bring those tomorrow morning. Any questions that you have, jot them down. You can bring those tomorrow morning. And that's about what we have for you. So thank you again so much for attending, for spending this time with us. We really appreciate it. And we look forward to seeing you tomorrow morning for day 2.